Mark, you're next. Let's if you can share your slides. Mark is from a famous rhinologist from Dallas, Texas.
So this is a mixed group, so I've got some wordy slides that I'm not going to read, but just kind of use the pictures, and it's to try to capture this for everybody that is, depending on where you're at, kind of tie it all together. So, when people come into your office and everything else, they really more describe where the pain is and really the difference between migraine, sinus pain, tension pain, any of those others is really not location. I mean, they show those kind of in the pictures, but you can see by that graph down there, a large percent of the location of pain didn't matter whether it was a tension headache or a migraine headache, which is really just defined by whether or not the migraine gets worse, whether you have either optic or neural hypersensitivity and the duration of the headache.
Yeah, we go.
Really, and you can see that it's migraine alone is just the WHO marks it as the most prevalent and disabling disease period, just for the effect it has over and the prevalence in general. So really getting into as more as a surgeon, I got into this from the opposite side, not necessarily the pathophysiology. My whole approach to mucosa is either do I leave it or do I take it out, not whether what it's doing underneath it, or same thing with blood vessels. So but as I was really looking at a lot of these baropressures and chronic baropressures, a lot of the nerve distribution, we think of it as V1, V2, kind of in these big things. But as you can see from this graph up, or this drawing up in the right, there are micro branches, and each one of the innervations of the face, like for example, bridge of nose is anterior ethmoid, and you've got the supratrochlear and the supraorbital, or you have the whole one, you have the facial zygomatic. Each one of these has a very, very specific nerve distribution. And if you kind of trace it back looking at CT scans, you can see that sometimes what thought to be referred pain, such like temporal pain and other things, or even V3 pain that's coming from the jaw joint, is actually directly being stimulated by some sort of pathology on that nerve. And I'll show some better examples here in a second. This is kind of more of the pathophysiology of migraine, and how that you can have CRGP has been shown lately or recently to be, which is a very significant vasodilator, to play a role throughout the trigeminal nerve, and it is produced through the peripheral branches and the ganglion in significant quantities, and has been shown to obviously play a big role in migraine and everything else. But it also then affects the nitric oxide, as well as substance P and pain throughout the whole brain. One of the things that people kind of looked at in migraine, and this is kind of a combination of the work done that was recently kind of championed by Dr. DeGillian in UC Irvine and Tuxedo up in Yale. They've did a lot of studies over the last 10 years that show when you trulate specifically V1, but all different branches, areas of the trigeminal nerve, you actually influence the paravascular blood supply to the cochlea, causing vestibular symptoms, pressure. In fact, there's some people that are now relating what they're calling otologic migraine to basically Meniere's disease. And this goes along to what Dr. Schusterman and Dr. Thorne showed, where they're showing this perivascular innervation, and you're seeing these kind of traces go all the way through. But they've done studies where they'll actually stimulate the supraorbital nerve extracutaneously, and they can then get VIMP testing, they can get nystagmus. They stop it, it goes away, it repeats it. These people also have a history of vestibular migraine. In those that don't, it doesn't do it. So one of the things, kind of getting back to how I started looking at this, is more in this barotrauma and baropressure. If you look at the kind of the drawings on this upper right-hand side, the left side is more normal anatomy, and you can have hyperpneumatization, but all of the neurovascular anatomy is protected by bone, and it's all an even distribution. On the right, you see these focal dehiscences where these neurovascular areas are exposed. This is by definition, pneumocystis is dilated. You get this hyperexpansion. It's first described in 1890, and it's thought to be a pretty rare disease, but it's really got three main characteristics that are seen on radiographic imaging. One is a hyperexpanded sinus beyond its natural borders. You have focal, not consistent, focal bony dehiscence, and you have a restricted. So as you look here, the histology is the bony remodeling that you're seeing from the bony biopsies. And you're also seeing in the below is PET scans in these patients where they've had on the left is normal, on the right is positive, where it's a sodium fluoride uptake. And they're showing increased bony remodeling basically due to there's two prevailing theories. One is a kind of a ball valve where you get air into this sinus, which hyperdilates it, and over time remodels due to the increased pressure. The second theory, and a newer one, is more that you have an increased concentration of nitric oxide, which then begins to cause bony remodeling and also some vasodilatory principles. So really looking at the ventilation of the sinuses in general kind of gets into getting the nitric oxide in and out, and barometrically, how big does that sinus needs to be, and what are we really looking for? In a lot of the CFD modeling, they've basically shown, and most of the average sinus osteums are between 3 and 5 millimeters. 2.5 has been shown on average in most situations to begin to change oxygen tension levels within those sinus cavities. And in fact, there's studies that have shown that if you go from 2 to 4 millimeters, you get a ventilation factor by 10. If you go from 4 to 8, you don't really get much change. So this is actually the nitric oxide concentration studies as well, which is interesting on inhale and exhale. But we used to think that the sinuses were ventilating and that you were getting oxygen in and out. But in a large degree, that nitrous oxide, which is heavier than air, is filling up most of those cavities and preventing a lot of the oxygen absorption. And so depending on the sizes, this is in regular people. Most of the nitric oxide that actually comes out on exhales to the ethmoid cavity with the larger ostium, not the maxillaries or the peripheral sides. So as we look at this is also this barometric kind of pressure. You can see if you've got either inappropriate gas concentrations, you're going to have a different gas pressure due to Boyle's law and Bernoulli's principle. And then you've also got, if you've got a positive pressure from a sneeze or a cough, blowing your nose, which can get up to almost 1,000 decapascals, will get trapped within that sinus. The barometric pressure outside is different. You have this chronic pressure that can cause sinus tension headaches, pressure headaches, because it's this bony cavity that doesn't allow for expansion, so you're getting pressure on the nerves. Now, if, like in this case, this is an example in the literature, and I actually flagrantly just copied their things because it was a patient with headaches, facial pain and pressure, trigeminal on the left, and if you can see, they've got these hyperdilated maxillary sinus, and a lot of times people will see the CT scan and say, hey, it's clear there's no mucosal thickening, which is absolutely true. In fact, part of pneumo sinus dilatans is there is no mucosal thickening within the cavity. But you can see it's actually expanding into the cheek and into that nasal cavity, causing nasal obstruction. During the time of surgery, the ostium was completely blocked and you couldn't actually see it on the CT scan. They opened it up, the facial pain resolved upon awakening. So what does that really mean kind of in general? Well, here's another example. This is actually, that picture is a patient of mine, had significant bridge of nose pain right in the V1 distribution. And you basically had an exposed V1. So, we were always taught to look for the anterior ethmoid canal and artery canal because of the risk of bleeding and the damage to bleeding. Interestingly, in multiple histology studies that they have looked at, there's only a blood vessel within that canal about 20% of the time. But there's the anterior ethmoid nerve, which is branches of V1. There are parasympathetics from branches of V2. And there's also sensory and olfactory things that have been shown to pass through that nerve. And when you look at the quality of the CT scans and why a lot of us haven't recognized this prior to this is because based off cone beam CT scans and more traditional sinus CT scans, both the thickness of the cut and the motion artifact of the patient prevented really being able to diagnose whether that bony canal was dehiscent or violated. And so as they looked at up to 60% on average is actually of the anterior ethmoid nerve is actually dehiscent. And in this case, in this patient, they had significant pain. This is a mucocele that had just formed, right? That is the anterior ethmoid canal. We took that, we opened that up and just sectioned that out. And all of a sudden that his pain was better immediately upon waking up. Now, interestingly, the reason that even is more unique to a lot of these migraine and kind of these trigeminal disorders that we look at and headaches is a lot of them have kind of these secondary symptoms or auras or other, kind of peripheral things that we've always thought or attributed to either direct CNS activity or some sort of pathologic process, neurovascular dilation, things like that. Well, this is a list of all of the normal trigeminal reflexes that are occurring within your body. Now, all of these are designed, obviously, to keep, your body tells you, the trigeminal tells you where you are in place, and then your body then responds to that in these certain ways. Now, if that nerve is exposed in a place where it's not supposed to be, you may be having a stimulation of that nerve that is then causing inappropriate reflexes like masseter tension, the cervical tension. We've measured the trigeminal nerve within these reflexes while doing these sinus procedures and changing the pressures within the sinus cavities, and you will get basically vestibular reflexes with sectional on the V1 in patients that do have vestibular migraine. You'll get the masseter reflexes in people that have sleep apnea, and a lot of these when they have these exposed different nerves. And so I'm going to go over, in the interest of time, I'll just kind of go through some of these just to see, we look at these CT scans and read them as normal. In fact, one of these, I showed Joe and he goes, well, that's a completely normal scan. I'm like, well, the radiologist didn't think so when they're actually looking, because of, like, for example, in this one on the left, he's got a complete and flattened orbital roof. It's dehiscent posteriorly. And you've got the supraorbital nerve exposed on the right. Well, remember, they've already done studies where they stimulate it right here and they get vestibular and they have nystagmus. So if you have a pressure change within that sinus, then you're able to stimulate that nerve and get the same vestibular reflexes on EMG. These is the posterior ethmoid nerve in the back. You've got your supratrochlear here, where again you see this kind of exposure, and you see on the right side where you've gotten that pressure where it's actually eroded into that orbit, and that you've got the kind of bony remodeling. This is the actually, and one of the things that we have found is a lot of times people will have either forehead pressure and pain and maxillary pain, mainly with sinus symptoms or weather changes, and they've undergone sinus surgery for the frontals and maxillaries, and they're continuing to still have barometric pressures, and they've always been told, well, I've told it's not my sinuses, they're wide open. And sure enough, they've had a draft 3, they've had they've ended up having a maxillary enterostomy, everything's wide open, but their sphenoid is completely opacified, the ostium. And they've got exposed V2 and they've got exposed V1 within the sphenoid sinus. When that sinus is then opened up, all of that pressure, barometric pressure, now resolves. So really looking at the location of the pain, and it's interesting, if you're looking at just infraorbital distribution, that is only right under the eye. All of V2, so if they're feeling it up in their jaw joint all the way to the bridge of the nose, that's more likely going to be from the root of the maxillary branch. Same thing with supraorbital. If it's just kind of right here versus this whole head pain, you're getting more the core branch of the trigeminal nerve versus one of the peripheral branches. And so you can see the superior orbital fissure here exposed. And these were confirmed by MRI as well. But you can see the arrow on that right side as it goes through. You've got here's the anterior ethmoid nerve as it goes across. And you can see one of the things that's interesting about this is I've seen this in hyperexpanded frontals and in the ethmoid. So you can get it in both areas and to look for it. Here on the left, you've got this kind of mucocele. Now, all of these patients, I do recommend getting an MRI, not only to be able to look for the neurovascular structures, but also in pneumosinus dilatans, especially with sinus disease. They've shown that there's about a 25% incidence of meningiomas or arachnoid granulations that they think is causing some of this intracranial pressure. And so this is external nasal nerve, which will be the kind of the side branch, which again is part of this reflex that you have for grimace reflex for different kinds of things. And if those are exposed, this is the pharyngeal nerve. So a lot of times I see this in patients that have a lot of ear pain and eustachian tube symptoms. There's actually there's a dual innervation to the palate and some of the eustachian tube muscles that actually go through both the Vidian nerve through basically the motor fibers come across on the facial nerve to the otic ganglion, but it passes through and goes on the intercommunicating branch, which to the Vidian nerve, which then goes through the SPG and then into the greater and lesser palatine. There's been a lot within ENT, a lot of interest in the posterior nasal nerve, both superior and inferior. And you can see in some of these cases, they're on the left, or I guess when you're looking at it on the patient's right, your left, you see that there's no bone over it, but on the right side, there is bone over most of that canal, so that it not only shows you where to ablate, or and people are getting into nerve ablation into these areas and locations, but they are in all different positions. Again, this is the infraorbital nerve, so again, this is going to be more just focused under the eye, not so much in the zygomatic area. You can see most of my patients, and I think it's because of the just Barrow challenge, they have hypernubitization through all of their sinuses and the mastoid, which is called pneumosinus dilatans multiforme, not just one individual sinus, which is what a lot of the original literature was. This one is, I don't see very often, but it is in patients like that have a lot of jaw joint or have been diagnosed with TMD especially. This is the foramen ovale and the exposure of the trigeminal nerve, the core branch of V3, as it's coming right off the ganglion in that sphenoid sinus. And you can see on the axials that there's thinning of bone right over that. So again, if that sinus has got pressure and indentation, or it gets infected or things back up, you're going to have direct stimulation, both positive and negative on that nerve, that can lead to a lot of the symptoms. Now, if it's acute and it lasts, there's really nothing to do. But if it's chronic, that's when you kind of look better. These are those zygomatic temporals that are branches of V2 that come off the SPG as it's walking across. And these are really this kind of headache that stops, but this will stop right in the midline. So if you've got facial pain and kind of mid-facial pain that stops right under the eye, that's usually you want to start looking more in posterior ethmoid or sphenoid areas, because you can find that it's not really affecting the infraorbital branch. So a lot of these neural patterns that this is the Vidian nerve, and this is actually the SPG, and I kind of show this for a couple of reasons. A lot of these SPG blocks that people have done, and a lot of the studies that have shown, they work in certain groups and don't work in others. Well, in this patient, and if you look at the far right, you've got that ganglion is fully within the sphenoid sinus. So there's no way you're getting a topical block to that area. And more importantly, that whole anterior face of the sphenoid is pneumatized into the nasal cavity. Here you're looking at the greater palatine, lesser palatine, and the different branching patterns and where it can be dehiscent in the maxillary. You've got the second branch of the trigeminal nerve in the upper left. You can see there is no bone under that area, and you can just see there's a kind of a pressure looking pushing up against that V2 as it's crossing the foramen rotundum into the SPG. So in a lot of these areas, and none of these are mucosally diseased, but they do have significant pressures that have been kind of described since actually the first description of this was in 1924, where you had these pressure-induced symptoms. And so as we begin to look at this kind of neural delivery, I think that one of the things that is really in the long run screwed up a lot of studies is that there's a lot of normal anatomical variance where a lot of this anatomy isn't where it's supposed to be. So for drug delivery especially, Is there just the mucosal absorption of the peripheral branches, or do you need more of the main trunk to see unmyelinated fibers? Like, what is it that you're trying to target? Because you're going to have, like, as you look at that one right here, where you see significant concha bullosa in this patient in the vertical area. You may have a pneumatized uncinate. You might have all these others that are stopping the airflow from either the olfactory epithelium or into those nasal cavities, mainly just because they have a paradoxical turbinate. The air flows differently than what's expected. And I don't think that we've ever had CT scans that are crisp enough where radiologists were comfortable causing whether there's dehiscence or not. And that's kind of shown in that anterior ethmoid study, where about 60% were called wrong when they did the anatomic dissections in the lab. So I'll kind of leave it for that and questions to try to not get too far behind.